I'm delighted this evening to be joined by Lisa Brackenridge. She's a nurse, or until January this year was a nurse, with 10 years experience in clinical research. She's now been forced to leave the NHS, essentially by her own conscience and standards, and she's now a candidate for the Freedom Alliance in Mid-Scotland and Fife. Lisa, welcome.
Hi, David. Thank you for having me on.
I want to start tonight by asking you, when the COVID crisis started, what were the initial things that left you feeling uneasy or concerned over the standard of care and the policies that were being employed?
Okay, well, one of the first things that I started to notice was that the normal flu screening had been more or less abandoned. So during my whole time from January 2020 to January 2021, I was seeing a lot of people coming in with respiratory illness, and normally they'd be given a flu screen, which has 8 different pathogens that are tested for, and then quite often a blood culture might be done as well, which pinpoints the specific antibiotic or treatment that is needed. Now, I only saw about 5 or 6 of these flu screens done during that whole year, which is extremely unusual. Now, I've worked in infection control for a clinical trial which lasted a year. And, you know, there are flu screens left, right and centre for people with respiratory illness.
Okay. I mean, this obviously, people will be aware that the statistics on flu have just fallen off a cliff. Flu's disappeared from the official statistics. And this has been somewhat unbelievably hailed as the great benefit of social distancing and mask wearing, although simultaneously it's not working for COVID, which is a very strange disconnect. But so you were seeing a clinical change. Was there any explanation? Was there any official notification that there was a different policy regarding testing for flu?
No, we get notifications frequently, you know, on a daily basis if policies do change via email. It's via the NHS email, and I didn't see any such notification. No. This
is strange and interesting, because of course we're getting other reports of changes in policy and changes in clinical practice, and there's never any paperwork backing it up. Down to very early in the process, I had a notification from indirectly from a Scottish hospital in East Kilbride that the policy was everyone over 45 was functionally a DNR, but there was no paperwork. There was no official line on this. It was then deniable, but the information I got is that's what was told to the clinical staff in a little meeting in a little room, but it doesn't seem to exist in terms of the paper trail. It's very strange.
Right. So you've just reminded me. I did a BLS training, basic life support, which is CPR, and I did that in around about April 2020. And I was told by the facilitator, we are DNARing everybody who is over 65 and over. And I said, well, surely we'll be doing that only if the ITU and HDU units are overwhelmed. And he told me in no uncertain terms, no, we're doing it currently. At which point my jaw hit the floor, and I looked at my colleagues and they said nothing.
That is well, it's confirmation of what we heard, but astonishing all the same.
Well, there may be paper evidence of that. I would imagine there would be.
Okay, well, we'll need to pursue that one. Okay, so flu screening was almost unknown. What other processes were you seeing that you thought were either troubling or dangerous?
Well, I was troubled by the fact that I saw two letters. So when a patient dies, there is what's called the final discharge letter. It's not a death certificate, but it is the doctor's final analysis of what the patient died of. It's their final diagnosis. And there's always a primary cause of death and a secondary cause of death. And so I had access to medical notes, detailed, very, I went deeply into these patients' medical records. So I knew what their pathway was. I knew what their medical issues were. And I saw that the two different doctors, had written as the primary cause of death, COVID, and the secondary cause of death, whatever their other issue was. Now, I know for a fact that this was incorrect, that the secondary cause of death was COVID in both cases.
So we've got DNR, we've got no testing for things which we would normally test, and then we've got misidentification of the cause of death.
Yeah.
Certainly stacking up. You were mentioning also concern over the actual COVID testing process. Could you explain your concerns there?
Well, one patient came in, he was in his 80s. He was given a COVID test, and he then had a nasal hemorrhage, which was so extreme that he lost so much blood in a short space of time that he ended up having cardiac arrest, ended up on the ITU unit. Fortunately, he didn't die, but he was critically ill for quite a long time. And I have huge concerns over the COVID test. It's very brutal. It shouldn't be used on anyone, let alone somebody with very friable, delicate skin, which is what happens when you become elderly. Also with children who have very tiny nasal passages. Nurses are not being trained properly to do this, and it's dangerous.
Yeah, I mean, this was one thing that a specialist nose and throat nurse that talked to the column was emphasising, that even with her specialist knowledge, she didn't consider herself qualified to administer this test without specialist training because of the danger of causing hemorrhage and even problems with I think it was spinal fluid, cerebral fluid leaking following the test. I mean, very concerning effects coming from the COVID test, and it does seem. I'm in no way medically qualified. It strikes me as unnecessarily brutal. I mean, I've seen the test done, and I've seen the pain that it causes the patient, and I'm wondering, is that necessary? I mean, normally if you're sampling for some sort of pathogen, it's saliva or a mouth swab or something quite benign, and then you see this very frightening process going on. It struck me as worrying.
It's not an MRSA swab. I've given hundreds of those, and that's a nice little soft cotton wool tip, and you don't thrust it hard into the nose. You just do a nice little sort of twirl round and under the armpit or possibly the groin, and it's not painful. It's not terribly invasive. It's not brutal, but this is brutal.
So you were seeing these things that were concerning you.
Yes.
How did that go? When you started to raise questions, what was the management response? What was the response from your colleagues?
I was overreacting. Comments like, well, if you had a relative who had died of COVID, then you would maybe be more sympathetic.
So they actually did that. That, I mean, just, we're going to use naked emotional manipulation to shame you for asking the question. That was where they went, and to a medical professional.
Yes.
I shouldn't be shocked now, but I still find these things shocking. That's the response that genuine concern receives. I mean, I'm my background, I'm an engineer. Okay, there are certain things that's kind of drummed into engineering as how you control risk. One of them is you need a culture where people can challenge authority, because otherwise authority will fly the plane into the hillside. And this has come from brutal experience. They had this particularly in Japan. Japan's got a very deferential culture, and they had one aircraft crashing, 200-300 dead people strewn over a hillside, because the pilot, who was the more experienced man, was making a mistake. The co-pilot knew he was making a mistake, but out of deference and respect, didn't say anything. And they actually changed it so that on final approach and landing, they tended to get the more junior person to fly the plane and the more senior person to supervise, because then he will step in if a mistake's been made. So this, having a culture where you cannot challenge authority in engineering terms is a known danger.
Mm-hmm.
And I find it shocking that message is not permeating something like the medical profession, where the dangers that you're dealing with are more immediate and more frequent than the ones that occur in engineering. It's you're dealing with these problems every day. Is that the right dose of a particular drug, etc. I would have thought and hoped that a culture of always challenging authority and authority respecting that would be the safe culture to have, and that doesn't seem to be what you found.
No, not at all. And in fact, one of my colleagues, we had a patient who had suffered a very severe trauma, was in ITU, had multiple brain injuries, spinal fractures, many fractures, internal injuries, extremely ill. Now, she had been at a house party, and this was during lockdown. And I happened to say to my colleague, have you visited, did you see patient X today? And her response was, yeah. And I said, oh, how is she today? I couldn't care less. She got everything she deserved. Yeah. Yeah.
Dear me.
Yeah.
Oh, dear.
So that really shut me up. I was, I thought, okay, I think I know what I'm dealing with here now. I need to, I need to be careful what I'm saying.
But this is, because this goes more than, this is not a medical malpractice issue. This is a cultural malpractice issue, because the spin, the propaganda, the constant drumbeat of fear and compliance, and if you don't comply, you're literally killing people. I mean, I had this in a bizarre exchange in a shop over mask wearing. I was trying to buy a pen, and I was on the phone, and I was aware that someone was shouting at me, and I turned around, and it was a shop assistant with his mask on, saying, will you put a mask on? And I looked at him and said, no. I went back to my phone call. And I was then berated by a member of the public who got extremely aggressive and sweary and abusive because I wasn't wearing a mask. So I went over to see what his problem was, and he was yelling at me that I was going to kill people. I said, no, I'm not. You know, I'm perfectly healthy. We don't, not that, I mean, I didn't go into the masks don't work issue, but there's no risk here. Why are you so angry? And he then panicked and said, you're too close to me, get away. And I looked at the gap, and we were about 2 meters away. So it's about 2 meters. You know, we're okay. And he wasn't happy with this, and he started to advance menacingly. He's about 6'4". He's a big lad. He started to advance menacingly to make me back off. And I looked at him. I said, "No, you can't advance on me because it's a 2 meter rule, and you know that doesn't make any sense." And then he kind of backed off and looked frustrated. But if he could have got close enough, he'd have thumped me one. He was so angry.
It's so ironic, huh? So ironic.
So the whole, all the norms of social interaction were gone. I'm sure under other circumstances, he wouldn't have been looking to start fights with someone quietly trying to buy a pen. It wouldn't have occurred to him. But because of the PR campaign, his view of his fellow man had so changed that was now an acceptable and indeed a necessary and good thing in his view to do. And I mean, it's shocking to hear a nurse say that, but it's the same basic issue that we're being taught to view our fellow man as a potential threat to our safety just by being alive and breathing.
Yeah, I know. The crazy is just, it's incredible.
Did you have any issues over mask wearing and these sorts of rules?
I did. Now, I was perfectly happy to wear a mask in the clinical area in A&E or any of the wards. I had to visit wards, I had to visit ITUs, I had to visit. So in any of these areas, I'm perfectly happy to wear a mask because I don't want to scare patients. You know, they're in a particularly vulnerable position. I wasn't going to have that conversation. However, in general corridors, I did not wear a mask. And I was harangued several times by my senior manager, who you know, would stop me in the corridor, and I would then say to her, "Listen, you know, I'm so stressed out. There's no way I'm wearing a mask." Now, this is me admitting that I have an issue that is potentially a health one. And she knows very well, as a senior nurse, that you should be having these conversations in private, not in a corridor, not about somebody's health. But no, she made quite an issue over it. And then if I was walking anywhere near the clinical area, she would point out, she would say, "You need to wear a mask in the clinical area." And I would say, "Yes, I am perfectly aware of that." But it was, I felt quite harassed by it. I kind of dreaded walking those corridors because I just thought, but on the other hand, you know, and I was told that I should wear a mask in my own office, which was a tiny little office. And, you know, my colleague had COVID, and I had been forced to quarantine for 2 weeks. I didn't get, you know, she ironically, she was the one who was wearing a double mask, sanitizing her hands every 5 minutes. But she got the COVID, I didn't. And my logic was, well, listen, you know, I'm sorry, I'm not wearing a mask in my own office. I need to breathe for these 8 hours. And if you want to wear a mask, then you go ahead. But it was very uncomfortable. It was very difficult. I stuck to my guns. But it, you know, I was not the most popular person in the department. Let's put it that way.
Yeah. So that to resist at all, we'll get this management response. We'll come maybe to more of that in a moment. Any other oddball rules that you thought just didn't stack up with kind of a rational approach to the problem?
Oddball. Yes. A senior nurse came in to our office one day and said, we are going to be putting cotton wool into the keyholes of the cabinet. At which point I thought, well, I've just slipped into an alternative reality. Really? Are you going to do that? So yes, so that's what they did. And then I said, well, I'm going to be opening the cabinet drawer in 5 minutes, probably. So what's going to happen then? You know, all the COVID's going to come flying out, or is it that it's going to go flying in? I am not sure. And you know, oh well, you're being confrontational. Now I said, well, I'm not raising my voice. I'm just stating the facts here, and I'm kind of questioning what the logic, what science is there behind this, please? Well, we've been told to do this, and this is
well, yeah. The science is we are only following orders. It's always the same. That's outstanding. Cotton wool in the keyhole. Okay.
Yeah.
Okay.
I pinched myself hard.
That takes a bit of processing as to the mindset that, again, we're going to say we're British. We're meant to laugh at these things, right? We're not meant to be running around in a flap, putting cotton wool in the keyholes of the cabinets in case the COVID gets in or out, not specified. Outstanding. Okay. Could we talk a little more about the management reaction to this? Because here you were raising some concerns about the appropriateness of the policies. Did you perceive in your colleagues a culture of fear to stay quiet? And what sort of management approach were you seeing?
Actually, things were quite relaxed at one point. It was only when my colleague got COVID that things started to kick off, because we certainly didn't wear masks in the tea room, and we didn't social distance in the tea room for months. It was only when the COVID infection, when my colleague got the COVID, that she, well, it wasn't so much her as all the other staff, or I presume the senior members of the staff, decided to take quite a lot of the chairs out of the tea room. They painted arrows on the floor. They started to do room inspections. Now, how on earth the pair of us were in a tiny little box room together, and yet other rooms were, had signs on the doors saying only 2 people in this room, and you'd go into it and it was quite a big room. And you think, well, why is it that we're in this tiny little room with no windows and no ventilation, and it's okay? So there was sort of mixed response.
Some of the bizarreness of it, I remember at the time, one of the first things that really struck me that this is weird. After we looked up what social distancing was, because what's that? So they'll never do that, and then they did. The next thing I noticed, I went into a motorway service station to use the gents, and in I went, and they had taped plastic over every second urinal, so you couldn't pee standing next to anyone. Now, you won't know this, but there's a certain code of etiquette with using urinals, and you would never pee next to the other guy. You always leave one, because that's how it's done, because it's an awkward thing to do. It's the most unnecessary safety precaution I've ever seen in my life.
Yeah. If it was Ebola or the Black Plague or something, I could understand it.
Yeah.
you know, and I've worked in infection control. I understand infection control. I'd be the first person who'd be advocating very stringent infection control measures, if I felt that there really was a risk. And also a friend of mine pointed something very important out, that, you know, why is it that if our masks are actually as protective as we are told they are, then why is it that we don't have a yellow clinical waste bin outside each supermarket or each public place? Why is it that it's okay to just take them off, drop them on the floor, and trample all over them? You know, I think we all know on an unconscious level that this is complete nonsense. It's not infection control.
No, it's not. It's psychological control. This is the point. Yeah.
Yes.
So you left NHS in January. That must have been a wrench. I mean, after a long career, and a career in which you'd achieved, you know, a level of seniority and trust and all that goes with that, to walk away from that, a very difficult thing. Maybe you can talk just a little bit about what that process was like.
Sure. I mean, it was disappointing. I'm hoping that you know, at some point there will be some sort of alternative health service that I can work within that doesn't operate like the NHS. You know, I'm being highly optimistic here, but yes, it was disappointing. You know, I really enjoyed working as a research nurse. It was a very satisfying job. However, it was a huge relief to get away from the hospital, because I mean, just walking towards it, you've got these Orwellian loudspeaker bits of advice given out by these voices, you know, and it was eerie, you know, and I walked to work, so, you know, I was in a good mood. And then the minute you hear this awful tannoy pumped sort of, you know, COVID measures stuff, or your heart would sink. And then you get into the hospital and you realize, okay, I'm going to, you know, for the rest of my shift, I'm going to have to be very careful what I say. And being careful what you say is draining. It's actually very, and I felt lonely. So I was actually relieved to leave. It sounds awful, but I was.
I understand. Now you left obviously before the main vaccine processes, vaccine rollout had happened. It was maybe just starting at the point where you departed, because that was sort of mid-December, the vaccine rollout started. So you might not have seen anything on the vaccine adverse reactions front, but could you maybe speak a little bit about the process of recording and handling the data surrounding the vaccine trials?
Sure. Yeah. This is important because a lot of my colleagues, amazingly, don't know what the yellow card system is. So even senior doctors, unless they have been in the research system themselves, and a lot of doctors, they seem to be able to avoid this. They don't know that when a clinical trial is being run, each patient is supposed to have a research nurse to monitor their adverse events and record them. Now, none of the people who are being vaccinated are being allocated a research nurse because they simply wouldn't have the resources to do that. So what's happening, or what should be happening, is that health professionals, nurses and doctors in particular, should have been trained in how to operate this yellow card system, so that if they did see anything untoward with the patient, then they would be able to flag it up to the MHRA. Now, you guys have been reporting on the MHRA serious adverse events. Now, the trouble with those statistics is that they are dependent on the clinicians to actually put their information in. And if most of them are not doing that, then there is no way of knowing just how many adverse events there are. This is a worry.
Now, one of the other aspects of that we've been hearing very strongly, and we heard a whistleblower testimony just last week, which was extremely moving, and from a nurse who had specialism in the vaccine field for many years, and it was all the more powerful because of that. So she was talking about the problems of lack of informed consent, yes, the lack of knowledge on the clinicians in order to obtain informed consent, and yeah, the patient information leaflet being withheld from the patients, or at least not volunteered unless specifically asked for. So there seemed to be a lot of concern over essentially the legality, over the correctness of the whole process, compared to the requirements of professional standards, Hippocratic Oath, etc., that should govern clinical actions.
So if you are involved in clinical research on any level, even if you're just a lab technician, you have to go on every 2 years. You have to go and get refreshed on your GCP training, which is the acronym means stands for Good Clinical Practice, and that encompasses a whole range of stuff. But the Nuremberg Code is at the base of it. So what's happening is that I have to pinch myself on a regular basis, because I can't believe that the MHRA is actually allowing this to happen. Because from my experience, they're a highly respected body, and people are literally scared of them when they come and inspect you, and they do that every so often. And people will go to an awful lot of effort to get their files and all their stuff in order, so that the MHRA doesn't close them down, because they've got the authority to do that. They're kind of like the tax inspectors of the medical world. And for them to actually allow clinical trials for the vaccines to go ahead without, as the nurse that you interviewed, that was a fantastic interview. She correctly says it's illegal to induce somebody onto a clinical trial without them being fully informed of not just the benefits, but all of the risks. And if you don't know what all the benefits and the risks are because the drug is too novel, then you have to explain that to the patient. It's absolutely 100% incumbent upon the clinician to do that. Everybody working in clinical research knows this. And also, yes, the patient information sheet is given, and no time pressure is put upon the patient. They can take it away. They can discuss it with their GP or anyone they want. They can take as long as they like, and then when they return, or when the nurse, usually a research nurse, contacts them, if they say, actually, I've thought about it and I don't want to take part in your trial, you are not allowed to say why. It's that strict. This is ingrained in us. For every 2 years we're given this. Not only are we given training, but we're also given helplines, so that if we are in a slightly difficult ethical situation, we can phone up and get advice, because we don't want to put a foot wrong there. You know, people end up in prison for running unethical clinical trials. So, you know, clinicians really worry about getting these things wrong. And the fact that we're you know, A, no informed consent, B, no patient information leaflet, C, no consent form. I don't know of anyone who's had to sign a consent form when they've gone down to their local vaccine centre. And yet they are on a clinical trial.
I'd be surprised if 1 in 100 who've had the vaccine know that it's at a clinical trial stage 3.
Well, even the clinicians aren't aware of it. I mean, some of them are, but an awful lot of them, if you say to them, you are aware that this is actually a clinical trial and that the patients need to be monitored and everything needs to be recorded and sent back to the MHRA, they look puzzled. Or they'll say something like, well, you know, it's had emergency licensing, so none of those conditions apply. Now, no, that's absolutely not the case. If you read the Nuremberg Code, which is what all of our training is based on, research nurses and doctors, then it doesn't say anything about, oh, there's an exemption under emergency rules. As far as I can see, it does not say that.
No exemption. No, quite right. On the general issue of medical standards and what the law is, we're getting lots of reports which are concerning. One which I'm looking to have a write-up published in the next few days was from the northeast of England, and a lady was taken unwell. She'd been mid-50s. She was dizzy. She had a racing pulse, 100 and something. Very high blood pressure. When the ambulance was called, she was feeling extremely poorly. The ambulance was called. People in the shop she was in at the time were lovely. They called the ambulance. She had a pulse of 103 or something, and she had a blood pressure of 140 odd over 110 or something. It was very, very high blood pressure, and she was taken to the local A&E. Because of her a personal history, I think trauma related in some way, she could not have her face covered. I mean, she would panic and become extremely distressed if she had her face covered. She was informed that she had to wear a mask in order to be treated at A&E, and she explained that she couldn't do this. And this argument went on for some time in the ambulance outside A&E. Eventually, the doctor or consultant came along and repeated this, and the ambulance men were trying to kind of negotiate a way for her to get into the hospital. She had enough about her, despite the distress of the situation, to say to the doctor, "Are you refusing to treat me? If you refuse to treat me and this is a stroke or a heart attack and something bad happens, you will be personally sued." So she was enough about it to remember to say that, and he could have backed off and said, "Well, no, I'm not refusing to treat you, but you have to put a mask on." It went nowhere. So eventually she left untreated, went home, phoned her GP. Her GP was very concerned because he thought she was having a heart attack and wanted her treated. And the next day, it was the next day when she actually got a GP. So the next day she said, "No, we need to get you into hospital." And the whole thing was so stressful, even discussing going back to hospital, she was lying down on the sofa. But they then found that the next hospital along had a completely different policy. So they phoned up and said, "No, there's no problem. If you're exempt and you've got your, something that says you're exempt, that's fine. That's not questioned. Come along." And so the next hospital along the coast, totally different. She went in, said the staff were lovely, couldn't have been nicer, no problem at all. So it was a very concerning story, because here you see someone presenting with a potential heart attack, or at least the legitimate concern over that, so that's what could be happening, turned away for not wearing a mask, and the person would become utterly frantic if their face was covered. It simply was not an option. This was not it wasn't a choice. It wasn't I'm defending my civil liberties. It was, she could not wear one. And the response was, well, we don't care.
I mean, I've heard a fellow nurse saying that they saw somebody who was having an exacerbation of asthma in A&E having to wear a mask. I mean, it's extraordinary, absolutely extraordinary. You know what? And I said, well, how does that work if they're wearing an oxygen mask as well? But apparently this actually happened. I mean, to put a mask on somebody who's potentially got a heart attack, I mean, it's reducing their oxygen intake, which is the last thing you want to do to a patient who's potentially got some form of heart failure. It's such a no-brainer. It's unbelievable. But I can believe that this is going on. Some people are just real sticklers, and they've become kind of they've got a sort of form of OCD about this mask thing and various other stuff as well. It's a very worrying phenomenon.
When we've got, what would you say to people who have relatives in hospital? Because there are these concerns over the way some medics are treating some patients, and there is certainly a concern over the changes in the clinical guidelines that are coming in, and the changes in policy, both written and unwritten. What can people do to help safeguard their relatives if they are taken into hospital? Bear in mind where they might not be allowed in to see them, or maybe only to a very limited degree allowed in to see them.
I would strongly advise ringing the named nurse of your patient, of your relative, and do that frequently. Do it at least twice a day. Make sure you speak to them. Make sure you get a synopsis of their care and their progress. And also, I would say, give the staff some sort of mobile device so that they can actually show you the patient. I think relatives and friends, they are not aware enough of the fact that they are currently the regulatory body. Without the relatives around, standards can slip. And I've seen it myself, especially in London hospitals, where they're very stressed, they're very short-staffed, and the morale is low. So if you feel that your relative is on a ward where the morale is low, where things may not be getting done as well as they should be, then you have every right to ring frequently, and it will annoy them. However, it will keep your relative safe or your friend safe. So I would strongly advise doing that.
Finally tonight, I'd like to understand what made you opt to go into the political world and join with the Freedom Alliance and stand for the Scottish Parliament. What prompted that, and could you tell me a little bit about what's happening with the Freedom Alliance and what you might be doing in the run-up? Are there going to be any hustings or any way where people can contact you to discuss your candidature for Mid Scotland and Fife?
Yeah, well, it's been a very pleasant journey. It's been nice to be with such grounded, sensible people. A lot of us are nurses. 20% of the Scottish candidates are nurses. We've got quite a few people who have a science background, but there are plenty of other backgrounds as well. But none of us is a politician. And I'm not sure if that's ever happened before with a political party. It's a very strange thing.
These are strange times.
Yeah, they certainly are. So it's good, you know, it's very good for my morale, especially after a year like last year, to actually be with people who are very focused on freedom and maintaining the laws, especially the medical laws. They really do need to be maintained. They're good laws. You know, they've served us very well for a long time. And they need to be kept as they are. We can't be going down this road of abandoning them and demanding that people will just submit their medical information willy-nilly to anybody or any IT agency. This is it's a breach of confidentiality. It's you know, your medical records should be yours, and if you want to give them out, fine. But if you do not, then you know, then you should have every right to say no, which currently we do, but this is under threat. So being with the Freedom Alliance folk is actually really great, because all of these concerns are being addressed, and working towards that is making me feel a whole lot better. I'm not just sitting around moaning about, oh my goodness, what can I do? It's, well, I'm doing something now finally, which is great.
And if people watching want to help you or want to support you in a practical way, what should they do?
Well, they can email me. I can't think of anything in particular right now, but I'm sure I could find tasks for people. I'm good at delegating. But yeah, you know, please vote for us. That would be really helpful. And please promote the fact that there is a political party that is actually going to be in opposition, because currently our so-called opposition only wants to lock down further and harder. And in my opinion, that is not an opposition, and that is not how democracy is supposed to work. So we will not be, we won't be, we will be trying to get the lockdown not just finished, but make sure that nothing like this can ever happen again, and that our medical laws and our freedoms can never be compromised or put into such a perilous situation ever again. And also, one of the aims is to hold the government accountable, especially for the care home fiasco and the thousands of people who would have died, who were denied medical treatment, sent back to their care homes, and you know, where there would be no high flow oxygen for comfort measures. You know, a lot of people would have died in a most awful way. People have to be held to account for that, and many other things. But that particular atrocity really bothers me.
Indeed. Lisa, it's been a real pleasure talking to you tonight.
Likewise.
It's been shocking at times, some of the things you've said, but a delight to hear your reasoned and logical approach, and the fact that you're finding like-minded people to stand with and to push back. So for all of that, thank you very much.
Thank you very much indeed.